Everyone, we will continue our presentation on the chest x-ray and what to look for. This is the third part, and I hope we may finish this presentation maybe in another two, maybe three parts. Last time we talked about the calcifications on the chest x-ray. We reached that. And we said we will continue with the calcification and whatever we can do more. Just a second, please. So, on a chest x-ray, the calcifications are most easily recognized using a low KVP films. That means a low voltage radiation. This will make the calcification more obvious and the bones will be more obvious. So if you are looking for calcification, you need to make a low KVP film. If you are interested in seeing calcifications, just tell the technician decrease the KVP in order to get proper demonstration of the calcifications. Of course, in the elderly, if you have seen chest x-rays of older patients like more than 60 or 70 years old, almost always we see some calcifications of the tracheal rings and the bronchial cartilages. We see them always, and they are just a normal aging process. It's not pathological. The commonest cause of calcification in the chest x-ray is tuberculosis. Especially if it's old healed tuberculosis. Usually it involves the upper lung zones, and chickenpox also might cause calcification on a chest x-ray. These calcifications are 1 to 3 millimeter in diameter each, so they are small calcific foci. They are regular in size and they are widely distributed. Do not mistake these calcifications for miliary TB or miliary metastasis. They are not miliary metastasis or TB because they are calcified. So be careful to distinguish between the tiny nodules of the miliary TB and the tiny calcific foci of chickenpox. Okay. For example, you can see here in the pulmonary TB in the upper lung zones bilaterally there are some calcifications, maybe more obvious on the left side, and this indicates an old calcified tuberculous granulomas. This is a chickenpox pneumonia. Of course, the chickenpox is healed long time ago, and the patient is left with widely distributed tiny nodules here and there. These are the chickenpox pneumonia calcifications. Other types of calcifications, we can see punctate calcifications diffused all over the lung. You can see these tiny nodules all over the lung, and you can see the prominent hyla bilaterally, and these are punctate calcifications of silicosis. And I'm sure if we look into a magnified view of the hyla, we can see some eggshell calcifications of the hilar lymph nodes bilaterally, typical of silicosis. Again, the calcifications might occur not only in the lung, but can occur in the pleura that surrounds the lung. These are plaque-like. These are like a paper or a leaf, and they are irregular in shape. You can see this one and this one. They are pleural calcific plaques. You can see here also, and these are very common in asbestos exposure, asbestosis. Okay, so if we see a shadow in the apex of the lung, and I mean by a shadow a soft tissue density, not calcification, soft tissue density in the apex of the lung, what are the most common causes? And these are not all the causes, but they are the common causes. They include pleural caps, pleural fluid, bully, Pancoast tumor, that is lung carcinoma of the apex, pneumothorax, and infections, especially tuberculosis. So let's talk a little bit about apical shadowing before we continue. Any questions till now? Everything is okay? Do you hear me well, and you understand everything I said? Okay. So the apical pleural thickening, or what we call it pleural cap. It is crescent shape, okay, just an angulated soft tissue density that is seen in the apex of both chests, okay, and it may represent old pleural thickening, okay. It represents old pleural thickening for whatever reason that causes the pleura to be thickened, and also it's seen in past Pancoast tumor. So how can we differentiate it? Is this a Pancoast tumor? Is this an apical pleural thickening due to old infection? Look carefully for the ribs, the adjacent ribs, especially the first rib. Is it notched? Is it invaded? Is it destructed? This will help you to differentiate the malignant Pancoast tumor from the totally benign pleural cap or pleural thickening, okay? If the shadow, the apical shadow is in the lung apex, it's a very common site for TB, fungal infections like histoplasmosis, coccidiomycosis, and aspergillosis, okay? So, for example, in this magnified view of the lung apices, you can see there is some fibrotic changes in the left lung apex, but if you compare it with the right one is a soft tissue mass that is involving the adjacent bones, and you can see some destructive calcifications here, okay. These are calcific foci from the destruction of the adjacent ribs, and this indicates a Pancoast tumor because there is bony destruction. So every now and then we have a case of an opaque hemithorax. The right hemithorax or the left hemithorax is totally white. So what is the differential diagnosis here? The differential diagnosis in opaque hemithorax, first of all, make sure that there is no technical error. There is no rotation, there is no scoliosis, because sometimes there is technical error causing opaque hemithorax, although it's uncommon, but be careful with that. There are some pleural causes of opaque hemithorax, like hydrothorax, yani pleural effusion, I mean. Large effusions, of course, should be large to cause complete opacification of the hemithorax. Sometimes pleural tumors like mesothelioma can cause that. There are surgical causes of an opaque hemithorax like pneumonectomy or thoracoplasty. Also some congenital causes like pulmonary agenesis, the lung didn't form from in utero. Mediastinal causes like cardiomegaly or tumors. Pulmonary causes like collapse consolidation in a whole lung can cause opaque hemithorax. Fibrosis also, and diaphragmatic hernias, طبعا big diaphragmatic hernias, not small ones. So in order to differentiate between all of these, we need first of all a proper history. We need history. For example, if the patient has a history of a surgery, we might think of a pneumonectomy. If the patient is young, very young, like infant, we might think of pulmonary agenesis. Patient have a history of heart failure, we might think of pleural effusion. History is very important, and we need to look to other things on the chest x-ray. For example, here you can obviously see that there are many ECG leads on the chest of the patient, indicating this is an ICU patient, okay, an ICU case, and you need to be sure that the x-ray is in erect position, not in supine. So here it's erect because in supine pleural effusion might cause total opacification, even though it's not big pleural effusion. Moderate pleural effusion in supine position can cause opaque hemithorax. Okay, you need to see the location of the mediastinum. Is it in the center? It's displaced towards the opaque hemithorax or opposite to the opaque hemithorax. This will makes a big difference in your differential diagnosis. And of course, you need to look to the bones, to the ribs. Is there any surgical fractures, for example? This will help us in the differential diagnosis also. Good. Now, let's talk about the opposite side. What if there is a unilateral hypertranslucency? That means one hemithorax is more dark, more aerated than the other one. Okay? Opposite, not opaque hemithorax, it's hypertransradiant. hyperlucent hemithorax. In order to differentiate that, we need first to make a proper comparison of both lungs, and this comparison, if you do it carefully, you will see any focal or generalized difference in the lucency of both lungs. Most of the times there is hyperinflation of the lung causing hypertransradiancy or hyperlucency of one lung. So you look for the signs of COPD or emphysema, such as splaying of the ribs. The ribs are displaced from each other, they are not tightly closed, okay? Or is there any separation of the vascular markings? The vascular markings on the involved lung will be less crowded than the normal lung. Is there any mediastinal displacement away from the hypertransradiant hemithorax? Because the lung is hyperinflated, it will displace the mediastinum to the opposite side. And is there any depression of the hemidiaphragm? Because the lung is again hyperinflated, will cause inferior depression of the hemidiaphragm. Most common cause of unilateral hypertransradiancy is patient rotation and scoliosis. Most common cause, there is the patient is not well centered, it's rotated to the right or to the left a little bit, so it's technical. And in cases of scoliosis, it will be almost impossible to make a proper, well-oriented, well-centered chest X-ray. So we have to deal with that. But keep in mind, if the cause is rotation and anyone asks you to which side it's rotated, the dark lung, the dark side, is closer to the film. So if the patient is rotated to the left side becomes more radiolucent than the right side. Okay? If the patient is rotated to the right side become more darker than the left side. Okay? So you can see not only by the clavicles and the spine and these things that we all know about, but also you can appreciate which side the patient is rotated by just seeing which side is darker and this side is closer to the film. Okay, now another common cause in in the modern age, modern surgical management of breast carcinoma is radical mastectomy, total mastectomy. It's an important cause, and you will see that the breast shadow is missing from one side, or in cases of bilateral mastectomy, you look for the axillary fold. Is it present or missing? Because in radical mastectomy, the axillary fold will be missing, and we will see some examples. For example, here you can see that this lung is hypertranslucent or more transradiant or emphysematous compared to this lung, okay? And you can see that the mediastinum, the heart, is a little bit displaced to the left side, okay? And this indicates that this is an emphysematous lung. This is an obstructive emphysema. And if you compare also, this is the right hemidiaphragm and this is the left hemidiaphragm. This is just the gastric bubble here. So the right hemidiaphragm is a little bit depressed compared to the left hemidiaphragm. Now, what about here? If you look carefully, this hemithorax, the right hemithorax, is more translucent than the left hemithorax, okay? And you can obviously appreciate that this is a female. You can see the breast shadow here, and you can see the axillary fold here. And if you look to the opposite side, you can obviously see there is no breast, indicating this is a total mastectomy case, and that if you compare this axillary fold, it's almost just this little bit of the axillary fold is present, and the rest is missing due to the radical mastectomy. So you should be careful with that. Of course, in cases of mastectomy, you always have to look in the lungs for any signs of metastasis, and you look for in the bones also for any signs of lytic or sclerotic or mixed lytic sclerotic metastatic lesions, because these are patients of CA breast. You need to be careful about that. Now, before we talk about pleural abnormalities, till now everything okay? Any questions, any comments? Okay, good. So let's talk a little bit about pleural abnormalities. What are the pleural abnormalities that we need to look for in a chest X-ray? First of all, the most common, we almost every day we see it, the pleural effusion. Other abnormalities include the pleural fibrosis or thickening, pleural plaques, pleural calcifications, tumors, pneumothorax, and fibrothorax. We will talk just briefly about each of them. First of all, regarding the pleural effusion, it's defined as a fluid in the pleural cavity. You can see it on erect chest X-ray. It's difficult to be seen on a supine chest X-ray. You will see just increased density of the involved hemithorax. So it's not easy to be appreciated on a supine chest X-ray. You need an erect chest X-ray, or you can see it in a lateral decubitus. The patient is supine but in lateral position. It will be even more sensitive than erect chest X-ray. So the erect chest X-ray, the commonest appearance we will see is an opaque meniscus at the costophrenic angle, just like here. You can see meniscus at the costophrenic angle, and the costophrenic angle will be obliterated, and the cardiac silhouette is also not seen. The heart is silhouetted, and we say the most common, we say previously, the most common cause of an abnormality silhouetting both the heart and the hemidiaphragm is the pleural effusion. If the pleural effusion is very large, the entire hemithorax can be involved and opaque, and because it's causing mass effect, the heart, the mediastinum, will be pushed to the opposite side, which might be normal or might have a less pleural effusion. Yani if we have a severe pleural effusion on the left side and mild to moderate pleural effusion on the right side, you'll see the heart is placed to the right side or to the less abnormal side. Okay? So, on the chest X-ray, what to look for in pleural effusion? First of all, blunting of the costophrenic angle. The costophrenic angle on the involved side is missing. This is probably the earliest sign of pleural effusion. And also the cardiophrenic angle is blunted, and fluid, because we said the pleural effusion will silhouette the diaphragm and the heart and the cardiac silhouette. Okay? Blunting, also fluid within the horizontal or oblique fissures is commonly seen. A meniscus will be seen, as we said previously, the meniscus sign that will confirm this is a pleural effusion. It's seen on the frontal films, and it will be on the lateral aspect of the hemithorax and gently sloping medially, while with large volume effusions, mediastinal shift will occur away from the side of the effusion. Different textbooks have different values, but approximately it's 200 to 300 milliliter of fluid needed for the pleural effusion to be detected on the frontal erect films, while in the lateral films, erect, you need as low as 75 milliliter of pleural effusion to detect, because you'll see the fluid accumulating in the posterior costophrenic angle. Okay, so if you are looking for pleural effusion, the lateral erect films are better than the frontal films. There are sometimes the pleural effusion will be in atypical position or will show atypical presentation. For example, there is something called lamellar effusion, which is collection of the fluid between the lung and the visceral pleura, not the parietal pleura. It's not in the pleural space, it's in the space between the visceral pleura that is intimately in contact with the lung surface and the lung. Okay? And it might spare the costophrenic angle because it's not in the pleural cavity. It is between the visceral pleura and the lung. This is called lamellar pleural effusion. Sometimes there is loculated effusion, which effusion occurs within the fissure. For example, this is a diagram showing the lamellar pleural effusion. You can see it here. It's between the visceral pleura and the lung, so it will not show the meniscus sign. It's just some sort of pleural thickening. You will be able to see that. Okay, but if you do CT scan, it will not be of soft tissue density like pleural thickening. It will be of fluid density because it's a pleural effusion. Again, this is an insisted or loculated pleural effusion within a fissure. Here you must be careful because it might look like a mass in the chest. So you need to be careful with that. Sometimes you can see that it's changing position. With changing position of the patient, the shape of this loculated effusion might change, and this will help you to differentiate that this is not a mass, it's a pleural effusion. And almost always it shows this lens-shaped pattern within the fissure. Another type of atypical pleural effusion is the subpulmonic effusion, which is seen when the fluid or the effusion accumulate between the diaphragm and the undersurface of the lung, between the undersurface of the lung and the diaphragm. So this will be difficult to appreciate or to report. We need to look for specific signs that might help us to decide there is a pleural effusion. If it's on the right side, you will see that the peak of the right hemidiaphragm, the dome of the right hemidiaphragm, is displaced more laterally. Okay, while if it's on the left side, you will see that the distance between the lower lobe and the air of the gastric bubble is increased. So there is a big distance between the lung and the gastric bubble. This might indicate a subpulmonic effusion. In this case, you need possibly a CT scan to confirm that there is a subpulmonic pleural effusion. For example, look here. You can see this is the right hemidiaphragm and this is the left, and you can see the right costophrenic angle is good. It's not obliterated, but this is the dome of the left hemidiaphragm, while the dome of the right hemidiaphragm is displaced more laterally, okay, than it should be. And this is an indicator of possible subpulmonic pleural effusion. Of course, you can see here some fibrotic bands indicating probably old healed infection. Now, what about pleural plaques? Let's talk about pleural plaques. What are the pleural plaques? What's the definition of pleural plaques? They are focal areas of thickening of the parietal, not the visceral, the parietal pleura. Usually it's due to previous exposure to asbestosis. Characteristically, they appear as scattered islands, okay, scattered islands of well circumscribed pleural densities. There is a pleural density or a soft tissue density here and here, multiple scattered, okay. You need to take AP and lateral views to confirm that these pleural densities or these opacities are situated within the pleura, not within the lung, okay. So you need at least 2 views to confirm. CT scan will help you with that if it is difficult to appreciate. Most commonly it's seen in the posterior aspect and the lateral aspect of the hemithorax. It's in the posterior and lateral parietal pleura, more in the lower third of the thorax. So you don't see much of them in the upper part, you see them in the lower part. And why is that? Because the asbestos fibers are heavy and they tend to go inferiorly, okay, not up. So the abnormalities will be in the inferior aspect, the middle and lower aspect of the hemithorax. They do not involve the costophrenic angle, and in fact most of the times they might be calcified, okay. Good. What about pleural calcifications? What do they mean? There are true calcifications, true pleural calcifications. They occur usually from asbestos exposure, and as we said, typically they spare the costophrenic angle. They do not involve the costophrenic angle, typically. Not always, most of the times they do not involve the costophrenic angles. Other causes of true pleural calcifications including old hemothorax, the hematoma will heal by calcifications. Also infections that involving the pleura, like they will cause pyothorax or empyema. There will be pus scattered in the pleural or accumulated in the pleural cavity that heals by calcification, causing pleural calcifications. Also tuberculous pleuritis. Of course, tuberculosis is a common cause of calcification everywhere, and rarely it might happen with extraskeletal osteosarcoma of the pleura. And This is a very rare presentation of pleural calcification to be osteosarcoma of the pleura, but we might keep it in mind. For example, you can see this is the pleural plaque here, it's calcified.